Hi everyone, welcome back to the channel. Today we're going to talk about something that we see very commonly in the wards and in medical casualty, a patient presenting with a high serum creatinine. The key question is, how do you evaluate this patient properly? And what exactly are you expected to do as a medical graduate? So let me start with a simple question. When a patient comes with a creatinine of, say, 218, what do you do? Do you immediately write to the nephrologist saying, "Patient admitted with creatinine 218, please do the needful"? If that is your first step, stop there. As an MBBS doctor or medical graduate, that is not what is expected from you. The first thing you must do is understand the patient, not just the number. So start with the basics. Patient's name, age, and sex, ward and bed number, comorbidities, and most importantly, why was this patient admitted? Creatinine without context is meaningless. Now comes the first critical question. Does this patient need urgent dialysis? Why do we ask this first? Let me give you an analogy. When a patient presents with shortness of breath, you don't start by searching for the final diagnosis. You stabilize first, give oxygen, correct hypoxia, and then think of definitive management. Similarly, when a patient presents with renal failure, your immediate goal is stabilization. And from a renal point of view, the only supportive therapy we have is dialysis. So we ask, are there urgent indications for dialysis? The kidney does so many functions in the body, but out of that, there are some essential functions. If those are not performed even for minutes, that would lead to life-threatening complications. What are they? First, volume overload. Second, uremia. And uremia has to be in the severe form, like uremic encephalopathy or uremic pericarditis. Third, refractory hyperkalemia. I am using the word refractory hyperkalemia because there are medical options to reduce potassium to a safer level. When it does not respond to medical treatment, then we call it refractory hyperkalemia. The fifth one is acidosis, which does not respond to intravenous or oral sodium bicarbonate. So these are the traditional indications for renal replacement therapy. As I mentioned earlier, pulmonary edema, uremia, refractory hyperkalemia, severe acidosis, and sometimes drug overdose or poisoning. But now the concepts have changed. We do not wait until these life-threatening complications occur to go for dialysis. If we delay dialysis, sometimes the patient's life is at risk. So the current considerations for initiating renal replacement therapy are based on clinical and biochemical parameters. We should decide whether there is a high likelihood of AKI recovering within the next 24 hours. If that is not possible, you will have to support the body with renal support, which means arranging renal replacement therapy. Going back to hyperkalemia, medical management comes first. First of all, you have to protect the heart, whereas hyperkalemia is dangerous in situations where it can stop the heart in a systole. Temporarily, we send the potassium inside the cells with the help of insulin and dextrose, plus salbutamol. But always ensure that the dose of salbutamol should be on the higher side, not for the bronchodilation effect, but to shift potassium into the cells and reduce the blood level of potassium. But that is not it. Potassium can rebound. So to avoid that, we need to remove potassium from the body. For that, we use some form of potassium binder, such as calcium resonium or calcium zirconium cyclosilicate, or Lokelma. If these measures fail, then only do we have to think about dialysis. The next step of evaluation is to decide whether this creatinine increment is due to AKI, AKI on CKD or CKD. So how do we decide that? There are two ways. One is if you have a baseline creatinine, and the second is if you do not have a baseline creatinine. Now, what is baseline creatinine? Most of us do not know what baseline creatinine is. We will see. Everyone knows the definition of AKI, that it is an increase of serum creatinine by 0.3 milligrams per deciliter within 48 hours, or 1.5 times of baseline within 7 days, or urine volume of 0.5 milliliters per kilogram per hour for 6 hours. Right? Here also the term baseline comes. The most recent, lowest, stable creatinine value is considered the baseline creatinine. But in our clinical practice, most patients do not come with a baseline creatinine. They may have been followed up in certain clinics for years, but they may never have checked creatinine in their lifetime. If it is available, we can compare the current serum creatinine with the baseline creatinine and take a decision on whether it is AKI or CKD, depending on the time duration. For example, if the serum creatinine was 151 months back, and the patient is now coming with a creatinine of 400, this indicates AKI on CKD. Whereas if it was 151 years back, and the patient is now coming with 153, there is not much rise in serum creatinine, which could be due to CKD progression itself. But most of the time in clinical practice, the baseline creatinine will not be available. So in that case, what would you do? If you have a doubt, you will have to take it as AKI on CKD. Why is that? If it is CKD, which means irreversible damage, we would not actively look for a cause of renal impairment, whereas in AKI, we would actively look for the cause and try to reverse the renal impairment. Another important thing is that we need to have an idea about the input and output to decide whether it is a volume-responsive acute kidney injury or volume-unresponsive. If it is volume-responsive, you need to hydrate the patient well so that the urine output improves and the AKI gets better. And if it is just the opposite, AKI is volume-unresponsive, you will have to reduce the intake so that the patient does not get iatrogenic fluid overload. So this is what we do if we know the serum creatinine trend. Additionally, we also look for whether there is any evidence of CKD. If it is present, it is more towards CKD, and if it is not, then as a diagnosis of exclusion, it is going to be either AKI or AKI on CKD. Now, what are the things we look for as evidence of CKD? The first thing is the patient's general appearance, whether the patient looks well or ill. For example, if a patient has a creatinine of 700 and does not look ill, this indicates that the renal impairment has been there for some time, and the patient has adapted to that creatinine. Whereas even if the creatinine is on the lower side, around 150 or so, and the patient looks ill, it is more likely to be AKI. So the general appearance gives you a clue. The second clue comes from radiological evidence of CKD. What are those? Shrunken kidneys with altered corticomedullary demarcation indicate chronic damage rather than acute damage. So if the kidneys are normal in size, the question arises, what is normal size? Anything around 10 centimeters is considered normal. Anything less than 8 centimeters is considered small and shrunken. But medicine is never that simple. There are CKD causes that present with normal-sized kidneys. What are those? Diabetes, which is the commonest cause of CKD, presents with normal-sized kidneys. The second differential diagnosis for CKD with normal-sized kidneys is myeloma. Anything that infiltrates the kidney keeps the kidney size unaltered. Polycystic kidney disease usually presents with enlarged kidneys, not shrunken kidneys. Another differential diagnosis is lymphoma or other infiltrative diseases. The third clue is native urine output. Usually, if it is AKI, the patient will tell you that the urine output has reduced, either anuria or oliguria. But when it comes to CKD, patients often say their urine output is normal. Why is that? Because the urine output declines gradually, not abruptly. So the patient does not notice the reduction, but if you quantify it in a ward setup, it will be on the lower side. The fourth evidence is biochemical: anemia, hypocalcemia, hyperphosphatemia, and hyperuricemia. These are biochemical evidences of CKD. If these features are present, it is more towards CKD. Your next job is to find out what could have caused the CKD. Whether it is diabetes, which accounts for almost 80% of cases, followed by hypertension, then chronic glomerulonephritis, polycystic kidney disease, and, in some parts of the world, CKDU. As a summary, the first question we try to answer when a patient presents with high serum creatinine is whether the patient needs dialysis. The second thing is the renal diagnosis, whether it is AKI on CKD, or CKD. The next important thing is that AKI or CKD is not the diagnosis. We need to identify what has caused the renal impairment. We have studied in medical school that causes can be pre-renal, renal, or post-renal. When it comes to pre-renal causes, we need to go through the history to find out whether there has been any volume loss, blood pressure drop, any cardiac cause where the heart is not pumping enough blood to perfuse the kidneys, or any liver abnormality that keeps blood within the portal circulation and compromises systemic circulation, leading to hepatorenal syndrome. When renal perfusion is compromised due to heart failure or cardiogenic shock, we call it cardiorenal syndrome. How do we manage pre-renal AKI? You have to identify the pre-renal mechanism. If it is volume loss, you replace the volume. If it is low blood pressure, you correct it with fluids and inotropes. If it is cardiorenal syndrome, how do you manage it? Since the heart is not able to pump blood into the systemic circulation, blood pools on the venous side. It is like a bullock pulling a cart and finding it difficult to pull. What do? You offload the cart. Likewise, we offload volume from the venous side. We do this by restricting fluid intake, restricting salt intake, and using diuretics to increase urine output and remove excess fluid accumulated on the venous side. This reduces the workload on the heart, improves pumping action, improves systemic perfusion pressure, and improves blood supply to the kidneys. When it comes to liver abnormality or hepatorenal syndrome, you need to become a Robin Hood. When the liver is diseased, it behaves as if it is the only organ that needs blood and traps blood in the portal circulation. Even in normal situations, the liver has dual blood supply, the hepatic artery and portal vein. When diseased, portal vessels dilate and sequester blood, compromising systemic circulation and renal perfusion. So, what do? We become Robin Hood, steal from the rich and give to the poor. We take blood from the portal circulation and push it into the systemic circulation. How do we do that? We use a vasoconstrictor that specifically constricts portal circulation without compromising systemic circulation. Terlipressin does this effectively. But squeezing blood vessels alone is not enough. The blood must stay intravascular and not leak into the third space because albumin levels are low due to liver failure. So we combine terlipressin with albumin to maintain intravascular volume, improve systemic perfusion pressure, and improve renal perfusion. This is how we manage hepatorenal failure. Now imagine holding both hands outstretched. Pre-renal is the left hand, and post-renal is the right hand. Once you have excluded both, only then do you come to the nephrologist. How do we exclude post-renal causes? Urine is produced, but the urinary drainage pathway is obstructed. We identify this using imaging, looking for hydronephrosis or hydroureter. If present, we refer to the urology team for intervention to relieve the obstruction. After excluding both pre-renal and post-renal causes, we come to the nephrology team. As you can see, so far the nephrology team is not really needed. This has been largely general medicine rather than nephrology. At this point, it is important to mention a very common problem we see in practice. Very often, the referring team does not understand the importance of a urine full report, which is a simple and basic investigation. Imagine referring a patient to the cardiology team without an ECG, or referring a patient to a chest physician without a chest X-ray. You can imagine how frustrating that would be. Another common scenario is that no attempt has been made to assess the input and output, which is a key component of volume assessment and an essential part of evaluating a patient with renal impairment. Once pre-renal and post-renal causes have been excluded, the diagnosis by exclusion is intrinsic renal disease. How do we confirm this? We practice evidence-based medicine. We cannot look inside the kidney directly. So we look at the end product of the kidney, urine. We do a urine full report and urinalysis. In urine analysis, we usually look at three things: pus cells, red cells, and protein. If you are asked what the use of urinalysis is, what would your answer be? To answer that, we must know how to interpret a urine full report. The first thing you look for is pus cells. If pus cells are positive, there is an ongoing urinary tract infection, and you cannot interpret the rest of the urinalysis. You must treat the infection with antibiotics after sending urine for culture, and then reassess. But if there is no pyuria and there is hemoproteinuria, it suggests glomerular pathology. That is the answer. It does not simply mean intrinsic renal failure, which is a broad term. Intrinsic renal causes include abnormalities of the glomerulus, tubules, interstitium, and vasculature. If the urine full report shows hemoproteinuria, it suggests glomerulonephritis. Then you need to assess the severity. We quantify proteinuria using urine PCR, or urine albumin creatinine ratio, ACR. If it is more than 3 grams, we consider it significant and label it nephrotic range. When it comes to hematuria, we need to differentiate whether it is glomerular or non-glomerular. How do we do that? If there is a significant proportion of dysmorphic red blood cells, it suggests glomerular origin, because red cells squeeze through small defects and become distorted. There is no clear cutoff percentage, but predominant dysmorphism suggests glomerular origin. However, the absence of dysmorphic RBCS does not exclude glomerular pathology. Why? If the defect is large enough, RBCS can pass without distortion, similar to how a negative NS1 does not exclude dengue. There is a term called RPGN, rapidly progressive glomerulonephritis. When glomerular pathology progresses rapidly with hemoproteinuria and rapidly rising creatinine, we call it RPGN. This is a nephrological emergency. When you suspect RPGN, you should have urine analysis showing hemoproteinuria, not just rising creatinine. Rapidly rising creatinine alone is RPRF or AKI, which can be due to glomerular, tubular, interstitial, or vascular causes. This distinction between RPGN and RPRF is very important. RPGN is an emergency, because delay in treatment leads to permanent loss of nephrons. In glomerular pathology, in 99 out of 100 cases, the mechanism is autoimmune. So, the treatment is immunosuppression. The level of immunosuppression depends on severity. Steroid monotherapy, antiproliferative agents, calcineurin inhibitors, cyclophosphamide, rituximab, or even plasma exchange. I have intentionally left out the remaining 1%. That 1% is infection-related glomerulonephritis, where treating the infection treats the glomerular disease. If the urine full report shows hemoproteinuria, glomerular pathology is likely, and the nephrology team should be involved. What about the other intrinsic causes, tubular, interstitial, or vascular? Unfortunately, we do not have specific tests to differentiate them, so it becomes a diagnosis of exclusion. If the urine full report is normal, with no hemoproteinuria, we presume tubular, interstitial, or vascular pathology. We then look retrospectively for causes. Tubular injury can occur due to ischemia or toxins. The renal tubular epithelial cells are among the most susceptible tissues to hypoxia. That is why the two organs most sensitive to ischemia are the kidney and the brain. When prolonged hypotension overcomes autoregulation, ischemic damage leads to acute tubular necrosis. Toxins such as myoglobin or herbal medications can also cause tubular necrosis. Once ATN develops, recovery is slow, and dialysis support may be required. But ATN can be prevented if perfusion is restored early. Similarly, exposure to nephrotoxic drugs like antibiotics, NSAIDs, or herbal medications can cause tubulointerstitial nephritis and AKI. Finally, vascular causes. If a patient has diarrhea, low platelets, low hemoglobin, blood picture showing microangiopathic hemolytic anemia, and biochemical evidence of hemolysis, think of HUS or TTP. Renal artery stenosis and renal vein thrombosis are rare and require Doppler studies. At the end of your assessment, you should write the diagnosis clearly. AKI or AKI on CKD secondary to what? The most common cause of AKI is sepsis, accounting for around 70%. About 20% is iatrogenic, mainly due to medications, and the remaining 10% due to other causes. Management follows the SHOUT protocol. S. Sepsis control. H. Hydration and correction of hypovolemia. O. Obstruction, exclusion, and urology referral if present. U. Urine analysis and targeted treatment. T. Toxin avoidance, including stopping nephrotoxic drugs. So this is how you systematically approach a patient with high serum creatinine. Logically, safely, and confidently, and answer for yourself 3 basic questions. Number 1. Does this patient need hemodialysis? Number 2. What is the renal diagnosis? Acute kidney injury, acute on chronic kidney disease, or chronic kidney disease? And number 3. What is the cause? If you found this useful, please like, share, and subscribe. More nephrology made simple. Coming soon. Thank you.